Welcome to Georgetown. And on behalf of the Georgetown University School of Health, the O'Neill Institute for National and Global Health Law, UNAIDS, and Friends of the Global Fight Against AIDS, TB, and Malaria, we welcome you to this event today. And I thank you to the teams across these organizations that have worked assiduously to make this morning possible. Our event today is titled New Thinking on Financing for Health and Pandemics in a Multi-Crisis World, Discussions on Health, Inequality, and Global Governance. We hold this event in a moment of deep and profound inequities here in the United States and across the globe, which we refer to here as our common home. My friends, our common home is grappling with COVID-19. We all know this, a pandemic that amplified inequality. And around the globe, while news reports and official figures of deaths from COVID-19 seem as if high-income countries suffered most, we know that's mostly a flaw in how the data are analyzed and how the data are interpreted. Excess deaths and analysis shows that the vast majority of deaths from the pandemic occurred in low and middle income countries. And they are not evenly distributed. Even here in the United States, last week, new data showed that life expectancy in New York City dropped by 4.6 years, the sharpest drop in nearly 100 years. But while white New Yorkers lost 3 years, Black life expectancy dropped by 5 years, and Latino or Hispanic by 6 years. And while these figures focused on New Yorkers, I think we can all assume that similar trends exist in other parts of the country. And these outcomes, well, they erase years of hard work that so many of us have done over the years to advance the equity agenda. Meanwhile, HIV/AIDS remains a pandemic, and we feel that keenly here in our nation's capital, which is why we are so pleased to co-host this event with UNAIDS and to have UNAIDS Executive Director, Winnie Byanyima, here with us today. Thank you for your time. And we are especially happy to announce today that we are signing a collaborating center agreement with UNAIDS and our Global Health Policy and Politics Initiative to advance the work on policy, law, and political analysis, specifically dedicated to tackling the inequalities driving the HIV pandemic. There's so much to do, and data shows that hard work remains ahead, with new HIV infections rising in way too many countries and communities. But in other contexts, global AIDS response also shows us what is possible in fighting the pandemic. In Malawi, for example, new HIV infections have fallen by 66% since the year 2010. We in the US, we wish that we had these same types of trends. And beyond these pandemics, there are deep inequalities across so many domains, whether it's about making healthcare more accessible to improve equity within countries or between countries, or addressing social, economic, environmental, or political factors that shape health. There's so much to do. And addressing inequality means addressing the financing of health across different sectors and determining how these approaches can reduce inequality instead of exacerbating inequality. Today, just a couple of miles away, the World Bank and the International Monetary Fund are holding their annual meetings. And in that context, we are pleased to bring you what promises to be an informative discussion on health and the future of health financing. Today, you're going to hear from some of the world's leading voices on health and health financing. You'll hear more about how fiscal crises facing many countries and many communities is undermining our collective health goals. You'll hear about burdens of debt that mean some governments are paying more every day to international creditors than they are in funding health. And you'll hear how those fiscal crises are interplaying with pandemic and political challenges across the globe. And we hope that you'll also hear from this esteemed panel about what we can do about it. This morning, we'll explore new thinking on how money can translate into better health for individuals into better health for populations. We'll also explore on how institutions guiding our global economy can work alongside public health leaders to tackle disparities on a global scale. And we'll delve into how financing health as a global public good can help address inequality issues like those that I see in my work with hospitals in the District of Columbia, as well as in community-based organizations. So from DC to Sao Paulo or Nairobi or Manila, these are the contexts in which we will explore. So our time together this morning is no coincidence. It is our hope that what you hear over the next couple of hours will stimulate your thinking and inform how you can use your own agency to get us closer to a world where all people can thrive and achieve optimal health and well-being. Moderating our panel today is my colleague, Dr. Matthew Cavanaugh, Director of the Global Health Policy and Politics Initiative here at Georgetown, which he directs for the O'Neill Institute and the School of Health. Matt is a faculty member in our Department of Global Health, and I must say it is his passion, it is his commitment for this work that made this moment possible. Matt?
Up to join me in these middle seats here. See if these are on. Good. Winnie, if you might come here, and Jarbas, if you might go there. Yep. Thank you very much. Wonderful. Good morning, everyone. Thank you all for being here, for joining us on what is a far nicer day outside than I had thought, and therefore it's especially nice that you've come inside. Although not bad digs, I must say. Winnie asked if this was similar to my office as I came in, and I said no. So we are obviously here at this moment of COVID-19, Mpox, and HIV colliding as pandemics. And we're also here as the IMF this week announced that we are going to see the slowest growth globally that we have since the 1990s. And that is a remarkable context in which we have colliding crises of fiscal policy, of financial realities for people's lives, but also pandemics that require response and greater preparedness, and then a wide variety of health challenges ahead. And so we're really thrilled to have this conversation today where we can ask, does this mean that when it comes to the idea of health as a human right, that there are not possibilities ahead? Do we have to kind of have lower ambitions? Or are there opportunities to imagine fiscal realities and ways to finance health that might help us actually realize the right to health, even in context of crisis? I don't know the answer, but hopefully other people here will. We are joined by a fantastic panel, and so we're going to start with a conversation with two of our panelists, and then add two more as we go. And so let me introduce them briefly. Winnie Byanyima is the Undersecretary General of the United Nations and Executive Director of UNAIDS. She is a health and human rights leader of world renowned, who previously served as an MP in Uganda, as a diplomat, as an agency in the agencies of the African Union and a variety of different UN settings, and also it was the head of Oxfam International. And so Winnie, welcome and thank you for coming to Georgetown. Dr. Jarbas Barbosa was elected director of the Pan American Health Organization by member states at the 30th Pan American Sanitary Conference on the 22nd of September in 2022. He previously served twice. At some point we need a story of twice. He previously served twice as the Secretary for Health Surveillance and as Deputy Minister in Brazil, and has held a number of different high-level positions within PAHO. And he just recently, as of February, has taken over as director of PAHO. And so welcome to you, Dr. Barbosa. So we are going to go ahead and dive in, and then we'll be joined by kind of two respondents, and then we'll open it up to this fantastic group of people who have assembled. So let me start with a question to you, Winnie. What are you hearing from governments as you do your work about, who are in the middle of fighting COVID still, who are tackling the HIV pandemic, which remains a pandemic, and are trying to finance their health overall, about their fiscal space and their ability to actually realize some of the global health goals that are out there?
Thank you, Matt. And it's a great honor to be here at this great institution, and also to be next to my brother here from the United Nations, from PAHO. What am I hearing? I work in the area of, our mission is to end AIDS, end HIV, end AIDS as a public health threat by 2030. That's my daily job. What I'm hearing from the countries with the highest burden of HIV is that they are losing it, that after 30 years of fighting this, 40 years actually, that the gains they have made, they are losing, and mainly because of the fiscal squeeze that they are facing today. Most of these countries are African countries. Many of them are low-income countries. They did not contribute much to the poly-crisis world that we are in. Very low carbon emissions. They are not responsible for the global warming. They are not part of the conflict, know almost nothing about what's going on with the war in Ukraine. But the impacts of the various crises they are facing, the harshest, they are on the harshest end of the poly-crisis. I'll give you some figures. Because these countries were borrowed, first, also, they had some issues. They were not raising enough domestic resources, even before this crisis. The tax levels were around 18% of GDP, hovering there. They were failing to increase their domestic collections. So they resorted to borrowing. They borrowed and borrowed and borrowed. But also, there was a lot of tax dodging. Some of the money, a lot of the money they should keep in their countries goes out through loopholes that are well established in rules, in laws, but that enable companies to take out and not pay their fair share of taxes. So because of a tax system that is not fair, they were not raising resources. They resorted to borrowing. But in the market borrowing, they were facing a very unjust financial system where they were borrowing, even before this crisis, at rates of 5 to 8%, where rich countries were borrowing at 1%. So even in terms of accessing resources, it was an unequal game. Then came the war, inflation, and everything that you know. Today, their debt repayments are taking the bulk of their revenues. Here's a few countries I can tell you where to show you how health is being squeezed out of national budgets. Kenya is paying the debt service, the interest on its loans, 53% of its total revenue. That's 9 times higher than its health budget, the debt reservicing. Zambia, a country that has been on the brink of debt distress, total debt service was 70% of its total public expenditure, 9 times more than what Zambia spends on health, 7 times more than what it spends on education. I could go on. All these countries, that is a pattern. On average, paying to service their debts 4 or 5 times more than they are spending on health, and in the middle of a health crisis. So this is the issue that's hurting the HIV response in most of these countries. They depend on the support, the goodness of the United States. There's a big PEPFAR program that carries a bigger burden. There's a global fund. But even these have not been, they are also affected. replenishment for the Global Fund. I see Chris here. Huge effort. We raised more money than ever before, but didn't reach the target of 18 billion. ODA, which is used by countries to support bilaterally, is being eroded, being used to pay for in-country costs of refugees from Ukraine, and repurposed and it's still called development assistance, but it's assisting the very countries that used to put it in the developing countries. So we're seeing a decline in the resources to fight and save lives in the middle of multiple pandemics, and all other social sectors affected. So this is the big problem. But there are solutions, and we can come to them. But this is the biggest challenge facing the countries with the highest burden of HIV, with COVID as well, in terms of delivering on the right to health. It's the fiscal crisis, and it's about inequalities in the global system, financial system, taxation system, even if you could call it the whole multilateral system, not delivering equitably.
Thank you. Let me turn to you, Dr. Barbosa, to ask, in very early in the COVID pandemic, WHO acted quickly and declared a public health emergency of international concern. And you've heard Winnie's thoughts on kind of where we are in a global space in a number of these perspectives. What we might imagine was that we've spent the period since that public health emergency was declared thinking about how to be, and there's been lots and lots of debate about how to be better prepared for a future pandemic. So my question to you is, here in the Americas, are we better prepared to finance the response to the future pandemics than we were in January of 2020? And what lessons have we learned or not when it comes to how we actually finance those responses?
Thank you. Good morning. Thank you, Matt, for inviting me to be here. Matt, I'd say that we are not yet better prepared. Not yet, because I think that the countries in the Americas, in Latin America, in the Caribbean, mostly they use a lot of money for the emergency response. And this was important to purchase the vaccines, medicines, to increase the number of health workers, also to establish some social protection. That was very important because, as you know, many countries in this region, in Latin America and the Caribbean, 50% of the economies are informal. So the public health measures before the pandemics, they didn't work properly in Latin America and the Caribbean because these countries needed to establish a kind of a network of protection to support the people that are not able to leave their houses every day to get their income to purchase food for that day or that week. So I think that this was important to have this kind of response. Also, the multilateral financial institution supported the countries, around $2.1 billion, mostly to purchase the vaccines. But this is not sustainable. First, because we need to have more funds now to be better prepared. And this, I think that this can be translated in how we can get the countries more prepared, each one of the countries, how they can get more human resources trained, how they can get more laboratory capacity, how they can strengthen the surveillance system and to have them integrated with health services. Second, that they need to implement some important lessons learned from the pandemic, how to build a more resilient health system. The pandemic was impacted not only, there was a very important impact, not only by the number of cases and deaths that COVID-19 produced, but also the social and economic impact, the levels of poverty and the extreme poverty increased, but also all the other public health priorities were impacted. Maternal mortality in Latin America and the Caribbean, we went back 10 years in most countries. We had hundreds of thousands of children that were not vaccinated with the routine immunization vaccines, people that delayed their cancer treatment, the people with diabetes and hypertension that were not able to get their medicine. So we have all these things that are calling the attention that we need to implement some things that the pandemic showed us that are better. We need to invest in the healthy workers. That is a very important problem for many countries. We need to expedite the process to implement some solutions like the digital transformation. We need to have also the health system better prepared for that. And this is a challenge because they are also facing this problem is the physical space is not very important, let's say so. But I am optimistic that for the first time we had a lot of attention about the health sector and how health is important for development and how a society cannot be developed if we cannot offer health access to everybody. So I think that this is the moment that we have to translate this attention that the health sector got to present proposals to strengthen primary health care, for instance, to have primary health care with more capacity to solve problems in the region. We need to present proposals to expedite the process to implement solutions, technologies, and interventions that are already available. I was talking with my dear colleague before, the PrEP coverage in Latin American and Caribbean countries is totally unacceptable. And is already there, the technology. We can use the pool procurement mechanism that you have at PAHO, the strategic fund, to offer medicines at an affordable price for the country. So I think that this kind of thing makes me more optimistic about that we can find a space to present proposals and to avoid that dialogue, the traditional dialogue. Minister of Health asking for more money, Minister of Finance saying that you need to implement a better management process. I think that you need both. And the best way to break this vicious circle is to present proposals. If I strengthen primary health care, I can avoid the death related to stroke. I can reduce the 30% of preventable deaths related to non-communicable disease that you have in Latin America and the Caribbean. We can reduce the rate of pregnancy among adolescents in Central America that have also high rates. So I think that if you can bundle these interventions in concrete proposals, maybe the health sector will translate this attention into a better financing. Now we have only the public expenditure in Latin America and the Caribbean is around 3.9%. As a proportion of the GDP. It increased in the last 10 years, but in a very slow pace. It's below the 6.7%, that is the average for the OECD countries, and even below the 6% that the countries in the America agreed to achieve 10 years ago. So I think that we really need to have health in the center of this agenda about in the agenda of recovering the economy and promoting social development.
So you're not as optimistic. Tell us.
But I agree very much with what you're saying. But why I'm not so optimistic is that I do not see the international community, governments, learning the lessons from COVID and being ready if we are hit and when we are hit by the next pandemic. I mentioned several areas where the global system must change. I mentioned the financing area. Every country, if we are to be ready and not be hit the way we were. Yes, all the governments were saying, now we see that health and economies are close. If you don't take care of health, you will lose your economy. They said that. But then the real problems to solve, one, the financing one, you need to get every country able to go into the financial system and negotiate its debt quickly and get the fiscal space to save lives in its country. Nothing is being done. We don't have an international financial system that is equitable where all countries can go restructure their debt and get money and solve and save lives. It's not happening. We are here, we are hoping to hear something coming out of the meetings here about debt restructuring. What we got in the middle of the crisis was G20 saying, okay, we'll suspend the debt for 2 years. That didn't give the space for governments to borrow and to be able to save. There was some money given as aid, but governments needed more and didn't get it. Then they came up with a common framework, G20. Again, 3 or 4 countries have been negotiating for 2 years and there's no end in sight. So no one has benefited, failed to work. So until there is a real restructuring of the financial system and enabling all countries, we are not getting there. In fact, during the crisis, I think our Secretary General has called it a morally bankrupt international financial system, and is right. In the middle of such a crisis, developing countries were sending out more money than they were getting to solve their problems. That's shocking. The banks themselves were called to the table to consider restructuring of debt. The banks didn't come to the party. They said that this would hurt their credit rating in the middle of a crisis. They wouldn't come to renegotiate debt. So we need then it's not only that, there are also other things like medicines, access to medicines. The vaccine was there, it was being hoarded because the trade rules allow monopolies to keep a price artificially high and keep people dying, have people actually dying because the price is so high, even when they used public money to develop that vaccine. The lack of transparency about their production costs and therefore their profits. Pfizer made a good almost 38 billion in 2021 profit. That's almost double what we need every year to fight HIV/AIDS. One company pocketed as profit as people died. So if you don't change that system of intellectual property rules, how will we be ready for the next pandemic? To me, we need some restructuring of the global economy to make the ground level. Otherwise, the system works against us. I won't talk about the tax.
I'm going to come back to the access to medicines, but I see you want to.
No,
I've got plenty of questions, but you can keep going, please.
Yes. I fully agree with your assessment about the situation. But I think that, first, we have an opportunity to advocate and to discuss for health that we didn't have before. Second, I think that we have some concrete opportunities to make the case about how to strengthen the response capacity, let's say so. First, we have this new instrument that are under negotiation. It's not an easy to achieve an agreement because it's talking about the sovereignty of the countries, talking about many important things. This will be approved in the World Health Assembly 2024, so we are supporting our countries to have all of them participate, because I do believe that one of the most important failures that we had during the pandemic was the lack of equitable access to protective personal equipments, to ventilators, to medicines, and to vaccines. So I think that this was a very important ethical, moral, and sanitary failure that we had. And this new instrument can change the game if we agree to really be better prepared for a new pandemic. And we also have this new financing mechanism. It's only 300 million. Only for the Americas, we had the letters of interest that are more than 800 million. So we probably need more money. But I think that this is also offering an opportunity to the countries to clearly not only say that we will only be protected if each country is ready to to detect and to act when there is a new virus, a new disease. It's not only to reinforce global mechanisms. They also need to be reinforced, but we need to act at the global level. So I think that this is a good opportunity to change the conversation, let's say so, and to call the attention that we need to implement the lessons learned with the pandemic and to strengthen the national infrastructure in each and every country will be the real way to be better prepared for a new pandemic.
Mm-hmm. So building on that, let me ask you both about, down the road, the International Monetary Fund and the World Bank are having their spring meetings, and there are, I don't know, probably as many different proposals out there as there are think tanks in Washington, D.C., about kind of what should happen. From a health perspective, how are you all thinking about what the IFIs could do that would get us into a different place? Because it seems like you both radically agree that we have had the opportunity to rethink things. We have not yet actually done the rethinking and the preparedness and the building of the financial infrastructure that's needed, but that we still have that window of opportunity. So as we think about the bank and the fund and the IFIs writ large, what is your perspective on kind of what they could do to evolve to be able to respond more effectively? Winnie, do you want to kick off?
Yes, I hear you use the word evolve. That is the word the World Bank is using. Evolution. I think I heard someone yesterday say it's not evolution, it's transformation we want. It's so important. There are some initiatives, and I think you're right to say that there's an opportunity to seize that the conversation is changing. There's a Bridgetown agenda. It's about financing, some proposals about financing better the multilateral development banks. And that is good. But then when you hear the bank saying it's evolution, you get discouraged. We do want to see very concrete measures to, like proposing the Bridgetown agenda, to capitalize the banks and to enable them to lend in their regions. That is a good step. We also have the negotiations on the pandemics treaty. That one is interesting. I have to be, again, cautiously optimistic. I will be optimistic, but cautiously, because the energy is mostly around the agenda of the rich countries, to be honest, which is that we want to strengthen surveillance and we want access so that when there's a health outbreak, we can quickly know where it is and contain it there and not have a pandemic. Very good. But developing countries are also saying, hey, we must not just be guinea pigs participating in ways to research to develop vaccines and treatments and then be excluded when they are discovered. We need also to have agreements about reforming intellectual property rules. But the rich countries say, hold on, that would take 20 years to negotiate. Let's put that in a slow track. Let's do the surveillance bit. So there is still an understanding of what it will take to be prepared, but not enough will to work on all the various aspects. But positively, there are steps being made to strengthen health systems on the ground. The African continent, which is the weakest one, committed, set a target for local production, increasing local production. And I've seen young people on that continent, brilliant scientists who have their own innovations for diagnostic kits, for treating hepatitis, for testing diagnostic for hepatitis, for even COVID. I know one a group of young men who had their test, and very efficient test, who waited until COVID was over before, WHO gave them certification. So there are scientists there, but organizing for local production, South-South collaboration and getting certified, these challenges are there, but there's determination and there are some steps being taken. in the African market to build up. So I'm not totally pessimistic, cautiously optimistic.
And Dr. Barbosa, building off of this, you in your kind of set of opening remarks, I think every single one that you've done since coming in February has pointed out both the inequalities between countries in the Americas and within them. And one of the things that has been variously on the IFI agenda has been tackling some of that when it comes to health. And so what are your thoughts as we think about kind of this IMF Spring Bank meeting moment that, we could think about in the international financial sector that might help kind of address the agenda that you've put on the table there?
Well, thank you. Inequality, I think that is unfortunately one main characteristic of our region, as you mentioned. We have established a very good conversation with the World Bank and the Inter-American Development Bank. Of course, that I fully agree that with the current levels of national public debt, it's totally if the global financing system doesn't offer any kind of new way to handle this national public debt, the developing countries will not be able to recover fully and to implement all the lessons learned from the pandemic. With the IDB and the World Bank, we have been working in some very specific things. One of them is how we can improve the quality of data and digital transformation in the countries in the Americas. PAHO developed a tool that assess the maturity level of the information system for health. And this develops to a plan of action, a roadmap about how to address the weakness. Countries in Latin America and the Caribbean have mobilized more than $600 million to support them. And this is not purchasing very expensive software. We are talking about how we can use telemedicine to reduce barriers, to guarantee that the primary healthcare units in remote areas attending indigenous populations that can be linked to specialized centers to improve the quality of care. How we can use cell phones to deliver messages, to monitor pregnant women, people with TB, with HIV, this kind of thing that can reduce the barriers and can guarantee more access. The second line is how we can strengthen primary health care. Again, primary health care in Latin America and the Caribbean is still focused on the same concept of Alma Ata that was established 45 years ago. In that time, it was a revolutionary action. But nowadays, if they don't offer, for instance, diagnosis and treatment for HIV or TB with high prevalence areas or for non-communicable diseases, we cannot change the situation that we have. For each 100 people with hypertension in Latin America and the Caribbean, only 50 are aware that they have hypertension. And only 25 have the hypertension control. And I mention hypertension because hypertension is the most important cause of death for adults in our region. And you cannot change this if you don't have the health workers trained, if you don't have the equipment to monitor hypertension and diabetes at the primary health care level, if you don't have them linked to specialized centers. And the third initiative that we are discussing with the banks is how to strengthen, I fully agree with you about it, that we need to strengthen regional capacity. Our countries struggle to have access to masks, goggles, gloves, to have access to ventilators after that, to have access to vaccine. We have some capacity in Latin America and the Caribbean. For vaccines, for instance, we have capacity in Brazil, we have capacity in Argentina, we have capacity in Cuba, we have some capacity in Mexico. So we are now, we have trying to, how we can enhance their capacity, how we can strengthen regulatory capacity, how we can use the pool purchasing mechanism that we have in order to be more able to predict the demand, in order to get more capacity to reduce this vulnerability. I think that this is also an important line of work that we are trying to implement the lessons that we have learned during the pandemic.
So let me pick up on that, because this is, you said when you first came in, Dr. Barbosa, that there was an opportunity for solidarity within the Americas, and that could be what's transformative, right, going forward. But obviously during COVID-19 that we did not see solidarity. So talk to us, and maybe I'll start with you, Dr. Barbosa, about what is the opportunity here to rethink access to medicines? Because we are in a context, you mentioned PrEP access, right? And, in HIV, as we think about PrEP access, we're actually seeing kind of challenges around kind of newest technology. We're seeing challenges on the newest HIV treatments as they're coming in. And this is in a sector that we have done a lot of work to actually reduce the price and create opportunities for access to medicines. Beyond HIV, we're even more challenged. So what do you see as a way forward that might be able to be politically possible to actually shift the dynamic when it comes to access to medicines?
That's a very important topic. We used to say that solidarity maybe was one of the first victims of the pandemic, because at the beginning there was no solidarity at all. I think that this changed after 1 year from the beginning. But I agree with you that we really need to see how we can translate solidarity in some concrete actions to increase the access in the region. I'm just give you one example, because this is a clear barrier. You know that we have now very good medicines that can cure hepatitis C. That's a very important cause of death for liver transplants. And at the beginning, the main medicine that is used for Fosbuvir was around $90,000 here in the US and in Europe. Some countries that started using, like Brazil, reduced the price to $10,000 for $5,000. Now it's around $5,000 the treatment. If a country in Latin America and the Caribbean does not have a patent for Fosbuvir, we can offer through the PAHO Strategic Fund the whole treatment under $2,000. So this, I think, that is telling us that you need to discuss about the IP rights and how we can use the flexibilities that are provided in the international agreements during a public health crisis and emergencies, but not only during the acute phase of the pandemic, but also for this recovery phase that we are. So I think that this is one thing. The other is that I mentioned two things that can translate solidarity in concrete things. One is this negotiation that's going on about the new instrument. They don't know yet it will be a treaty, a framework, an agreement. But one very important thing that has been discussed there is about how to support the countries financially, but also how we can guarantee equitable access from the beginning. If we let the market rules during a pandemic, it will be the same thing that happened in this one. The producers will sell individually to each one of the countries, and for the richest countries before, and the developing countries will only have access 6 months, 8 months, 1 year after the vaccines are available. So I think that it's very important to find a way to guarantee equitable access this moment. This is the concrete way to translate solidarity, is to guarantee that every country will have the same right to access the tools that they need to respond to a pandemic.
Winnie, let me come to you and just push you. I know you've got a few thoughts on access to medicines writ large. What are some concrete pieces that you think that we could actually do right now? We're clear on the kind of crisis that came in COVID-19. We're clear on the barriers on HIV. We're clear on a number of them. But what do we actually do about it right now?
I will answer that question as a woman from the South. We suffered the indignity and the pain of seeing people dying when there was a life-saving vaccine. That really, I think, touched many, many people deeply. And the resolve now to build local capacity in every region is strong, particularly in Africa. We suffered the most. But I see this as an agenda for all the South, the developing countries, the middle-income countries of Asia, of Latin America, the low-income countries and middle-income countries of Africa, their leaders getting together and really finding ways of using South-South collaboration to transfer technology and build capacity in each region. We have the Brazils, the Indias, China sees itself as a developing country still, and South Africa. There is a huge opportunity there for scientists who have, in a region like Africa where you do not have manufacturing capacity, but you have great scientists who make innovations, to partner with manufacturing companies in the other countries with the capacity to produce products that are locally made, even though the manufacturing is outsourced, but the technology is being generated on the continent of Africa or in the countries of Asia without capacity. So the opportunities are there, and I'm beginning to see that happening, the integration of markets so that you can sell everywhere. But we still need very much that the international organizations, such as Global Fund, Gavi, PEPFAR, that procure in bulk, to guarantee and buy from these emerging initiatives on a continent like Africa. They have to guarantee. And in that regard, I do commend my colleague, John Nkengasong. I heard him recently announce at PEPFAR to circle out 15% of their procurement of certain diagnostic commodities to African producers. That's a step. That's a step forward. We need to see more of that. And we need indeed to see in this pandemics treaty the track on access to medicines also moving fast. You not just have the track on surveillance and data, but also the track on access to medicine. But I see the potential in the South to build up capacity quickly. It will take political will, it will take investors, it will also take the international community to support. Yeah, thank you.
Let me invite our esteemed respondents to come up to the stage, and I will introduce them as we do. So Justice and Joanne, if you might make your way up. Let me introduce them as they come up. Professor Justice Nonvignon, you're going to stick around, Winnie. Don't go. No, you guys have to stick around as well. So Professor Justice Nonvignon is the head of the Health Economics Unit at the Africa Centers for Disease Control, the Africa CDC. He is also Associate Professor of Health Economics at the School of Public Health at the University of Ghana, Legon, and has led a variety of different commissions and working groups in Ghana and globally that have been really hugely impactful when it comes to health economics. And Dr. Joanne Carter is the Executive Director of Results, an organization that combines sharp policy analysis and work in the halls of power of global health with grassroots organizing, and also leads the Action Project, which has driven billions of dollars in investment with more than a dozen countries on 5 continents on access to health overall. So let me ask you two, now that you've heard thoughts from our first 2 panelists, and then we'll bring both of you back in. Let me ask you both to respond, and I'm gonna start with you, Professor Nonvignon, and I'm curious, especially, you know, as an economist, let's come back for a minute to where we started this conversation, and you heard kind of optimism and pessimism, and an agenda for the IFIs at this moment. Sitting as an African economist at Africa CDC, where do you come in, and what's your reaction to what you've heard so far?
Thank you very much, and I'm happy to be on this stage with colleagues. Let me say that I find myself firmly in between Winnie and Dr. Barbosa. And I say firmly because I am partially optimistic. And I'm coming from the period before the pandemic. You know, as an economist and as a health economist, I always say that there is nothing good about this pandemic, but it has brought the attention of policymakers from the global to the country levels to health, you know, at least closer. So that's a good thing. And so it's elevated at least the conversation about health investments beyond what it used to be. And Winnie has done a great job by, saying what it is with the global financing system. It is inequitable. It is not fit for purpose. And so we need to start the conversation from that angle. There's a lot that we need to do about the global financing system. And what I am failing to really feel from the conversations about the new pandemic fund, about all the initiatives, is that we at a global level are still seeing health more as a social good. I mean, we say it that yes, the pandemic has helped us to see it more as an economic good. But in the discussions, in the IMF negotiations around the debt-distressed countries, and my country is one of them, as Winnie mentioned the debt service levels, my country, Ghana, has more than 70%, probably 80% of money going to debt service. And we are one of the countries that is firmly with the IMF now. But I would love to see, as a part of those negotiations, the thinking around health not only being a social good, but also having the potential to generate economic returns come up strongly. We've seen that. We need not go any further. COVID has taught us. I mean, if people get sick, they cannot work for a week, you immediately see effects. And in fact, the revised growth targets that the IMF has given, what contributes to much of that? Is it not the COVID pandemic? So we need to move the conversation around seeing health, because if our development banks, if the global financial institutions actually see health as a potential to generate economic returns, we will trade it differently in terms of, financing and things like that. So that's one of the things that I want to say. But, well, not but. And, where I come from in Ghana, we say there are a couple of adages. One of them is that as you advise the cat not to get into the kitchen, and so that it doesn't see the fish to pounce on the fish, you also need to advise the fish to hide, right? And I think that this is where our countries come in. In 2001, African countries pledged to spend 15% of their annual budget, dedicate that for health. Not even spend, but at least dedicate. And as I checked, the latest data shows that for each year in the past 20-something years, we have not had more than 3 African countries actually meet that target. We haven't had that. And when people talk about the debt and say that, yes, but countries do not have the space to spend, I say, yes, that is true, but countries can actually increase a little bit. I mean, we saw a glimmer of hope when the WHO latest World Expenditure Database, the report said that within the pandemic, the years of 2020, 2021, in fact, the largest increases that we saw in spending for health, came from government sources locally, domestic sources. So that is good. But I think we need to systematically get our countries to prioritize health a bit more. And that means engaging with the finance ministries. We are not very good at that. Dr. Barbosa and I were discussing that early on. We are good at projecting the health gains, that we'll make from health investments. But the ministries of finance are also interested in looking at economic gains. We can do that because we've seen that. We've seen that if people don't work for a number of days, productivity goes down. So we should be able to do that. So let me end by saying that our countries, we've seen the global financial system not being as strong as it could be. And in the current discussions, I think we could do a bit more. We need to elevate health beyond seeing that as a social good. But we also need to get our countries to begin to appreciate that a little spending from their efforts would help. we cannot continue relying on DH. You know, what happened during the pandemic when African countries realized that, look, we cannot depend on global mechanisms. We need to get our own vaccines. People would act. So I think there is, I am partially optimistic, and I think that there are lessons from what is happening now for us to be able to inject more efficiency into the spending, even the little domestic spending we have now, as we seek to improve that and hope that the global financial system will recalibrate itself to do away with the inequity issues and some other ways that it could help, boost our own spending.
And just in brief follow-up, you're here in Washington for the IMF World Bank meetings. Are you coming with an ask? Do you have an ask to the IFIs? If you were to kind of ask for one thing, here as we're thinking about this space, what is it that you're hoping they might do this week, if you've got any? Not to put you on the spot.
Yeah, that's true. I mean, I'll follow up.
I've totally put you on the spot.
Yeah,
so
sure. I'll follow.
Feel free to just say, as I was passing over to Joanne.
No, I think as Winnie said, these discussions at the very highest level. I know there are many ministers of finance, from Africa at these meetings. The whole of Africa is watching to see if the global, let me not call them powers, but the global, financial institutions would actually hit and make decisions that my grandmother in the village would feel a bit better. In terms of dedicating a bit more space, in terms of really having a very frank discussions around the debt service issues and see how we can lift our hands. I do not often want to say this, but sometimes it feels that as global players, we turn our eyes, our faces to agree that, yeah, there's something we need to do, but we use one hand we have one hand actually on the local person. So within the country, we want countries to get out of their debts, but at the same time, we have our hands on them. If we could lift that hand a bit and allow countries to breathe while we ask them to spend more on health, I believe that would be a step in the right direction. And in fact, that's what many African people, not governments, but people within the villages are looking for, that we would be able to breathe a bit more out of these discussions around debt service and prioritize health more, as I said earlier on.
Thank you. Let me turn to you, Joanne, to ask, your reactions to the conversations thus far, and specifically around, the IFIs and some concrete pieces that we might be able to do. There's a kind of real macro level conversation that's happening right now around, both debt and how do we stabilize the global economy and how do we worry about the banking sector. But there's also a ton of micro level conversations that are happening in the town right now about what would it look like concretely to actually be able to inject kind of finances there. So over to you for kind of any reactions you've got, but also if you have thoughts on concrete actions by the IFIs, we'd be interested.
Yeah, thanks, Matt, and really great to be with all these other these global champions and global leaders. Maybe a couple of observations and kind of cautions, even, and then some thoughts on ways forward. I kind of start with, and colleagues really implied this, but maybe I want to say it a little more pointedly. We have got to avoid and challenge this false choice between stopping future pandemics and fighting the current ones. You spoke so powerfully about, what we need to be doing is investing in primary health care, investing in healthcare workers, strengthening those systems, and so that, and also the real danger, so that pandemic preparedness and response is not about surveillance to protect people in wealthy countries. It's about building out the right to health for all. And also, how can we have serious surveillance if there's people that aren't even being reached by the health systems? And I say that this is not a theoretical issue because, in the president's budget this year, there was a big new set aside for global health security, including a new and frankly untested yet pandemics fund. And yet there were cuts to bilateral HIV/AIDS PEPFAR programs, TB programs, and the President's Malaria Initiative. And kudos to the administration. They played an incredibly important role as leaders in the Global Fund replenishment, and that funding was there. But to sort of cut these bilateral programs at a time when, number one, they're recovering, but number two, they were the backbone in many cases of the COVID response. I mean, Winnie, you could say more about that. All of you could. I've been working on the issue of tuberculosis for 20 years. In Asia, a large part of the COVID response was built on the back of TB programs because they're airborne infectious diseases and the very same things that were needed. Unfortunately, because those programs, neither COVID response nor TB was well funded, you pulled funding away from TB for COVID and you had pretty devastating impacts. And that's true of all three of the diseases. But I think we have to really avoid those kind of false choices and in our financing too. And I would also say when we look at financing mechanisms, I think we have to look at the ones that are actually creating and supporting those kind of synergies and with proven impact. And I would say, that's things like the Global Fund and, as well, even with some of its challenges during the COVID pandemic, institutions like Gavi and others, CEPI, WHO, Africa CDC, and others that really are helping build national responses and national systems and creating those synergies. And frankly, wanting the Pandemics Fund to be effective, but just wanting to be really cautious that we don't put all of our sort of hopes of a response on pandemics on a new and kind of untested fund that, done wrong, could really silo those things. And then I guess I just wanted to say also one other observation is somebody said early on, talking about pandemic response as a global public good. I think there's values to that, and it's totally true. But, talking about the meetings happening just a few blocks from here at the World Bank and IMF, in an earlier version of their Evolution Roadmap paper, there were some real red flags about how they talked about pandemics as a global public good, because they talked about prioritizing the externalities. So in other words, if there were real external benefits to this, we would prioritize that. And if you took that to a sort of perhaps slightly negative, down the road, it could mean that you would be prioritizing surveillance and, zoonotic spillover monitoring over actually building national systems. And they've actually walked that back in the most recent paper. But I think we have to be really cautious about, yes, a global public good, but it also doesn't exist on its own. It exists embedded in building national systems. So, I think that, and I also just want to really, support and reinforce, we have to find ways of financing regional capacity, whether that is PAHO or Africa CDC, and also that regional manufacturing. And, it's encouraging to me, not just what PEPFAR is doing, but also that Gavi is talking about it, that this could come up in their midterm review about funding, support for African manufacturing. And Matt, just to wrap up, the things I would say about, some specifics about financing. One is, Winnie, you said it so powerfully and eloquently, and as you followed up, we have to work on debt restructuring. We can't just lay out the problem. We actually have to hold lots of institutions, but really the multilateral development institutions to not just identify the problem, but actually convene on the solution. And also, while they may not be the biggest burden of the debt, they actually have to take action themselves. And I appreciate both partners in country that have been pushing that. And I also appreciate partners in the One campaign that have really been raising that issue and calling on the MDBs to take, action themselves on this, as well as that kind of convening. I also think we have to look at the scale of resources from the multilateral banks, and particularly the World Bank. It is the largest source of development finance. We have to make sure that in this sort of, if we want to call it a post-COVID world, that the focus on health and building health systems does not fall off. And similarly, we're going to see, they're already talking about what's going to happen in the next 3-year replenishment of IDA. We have to really elevate health and supporting both national, but also these kind of really regional investments that support national investments. And I just end by saying, we have to think about, also what do we do for middle income countries? How do we create more concessionality without using precious ODA? It's going to be really important for Latin America, but it's important for Africa and elsewhere. And I would just point to a couple of things. One is whether they like to do it or not, the MDBs have to do better with their own balance sheets. We have to max that out and then look at what's possible next. But also, like, some really interesting strategies. The Global Fund and the World Bank, and I know this because I work on tuberculosis, did a couple of really interesting co-financing or buy-downs, and they actually, the Global Fund invested $40 million in a $400 million loan to India for TB that brought that down to a concessional rate. It was a 10-to-1 leverage. And just more recently, they did this with Indonesia. $20 million from the Global Fund created a $300 million loan for TB. So it was more than the economists can do the math faster than me, but more than 10-to-1 leverage. So using those kind of strategies, they seem kind of micro, but they could really matter. And finally, I'd say my colleagues who are here from that we work with global health advocates in France, and just put out a really interesting paper called "Making It Work: What Role for the MDBs in Financing for Health for All," and made a really important point. Like, we have to increase the kind of quality and equity. Like, how do we increase the quality of those flows and their impact, but also how do we use those to leverage equity? And really, promise, very last point, how do we improve the governance? And governance is not about just who's sitting around the table, because you should have the right people around the table. It's that you will not get the right decisions at national or regional level, or the right impact, implementation of programs at country level, if you don't have civil society and communities, but also even national governments and parliamentarians, around the table as part of those processes.
We're going to open it up to discussion in the room. And as we do, this is a room actually full of people who could also all be on this stage. And so I will take the prerogative to say, while questions would be good, we'd also welcome inputs. So it's kind of the opposite of an often moderator thing, which is only ask a question. I mean, given who's in the room right now, we'd really welcome thoughts. As folks are thinking about it, I don't know if Winnie or Jarbas, either of you have kind of reactions to what you've heard from Justice and Joanne, please.
Thank you. I'd like to pick up one point made by Joanna, which is that to be prepared for the next pandemic is about, I'm rephrasing it, is about being able to fight the existing ones. We've said this again and again, that first, HIV as a pandemic that's been there for 40 years has transformed global health. And what has been put on the ground in countries in terms of the labs, the communities that were trained and that are involved in leading, the awareness in the population, the policies and frameworks for fighting the pandemic have worked. We've seen them come to work for fighting COVID. We saw that those who used the infrastructure, both physical and social infrastructure that existed for HIV, responded quickly. So now, coming to being prepared for the next one, it's about continuing to invest in these, pulling the whole system that is outside actually the formal health system, and not necessarily formalizing it, but connecting it tightly and empowering it to serve whenever it is needed. All the people who are well-trained, all the civil society leaders, community leaders, the services that they deliver that are so under-resourced today, that being prepared is actually resourcing them. We are launching a report. Let me do a little marketing. We are launching a report today showing what we call the triple dividends of the HIV response, showing that when you invest fully in the HIV response, not only will you be saving lives, but you're contributing social benefits, social outcomes, and economic outcomes, to your point, that you will reduce the number of orphans that are the result of loss of lives of adults. You will increase the number of children, and particularly girls, who will be alive and who get educated and who will be a human resource, a capital, human capital, part of human capital, that you will contribute socially, social benefits as well as economic benefits. We will be launching this report today. And I think we need to make this argument again and again and again moving away from seeing health as welfare, social benefit, and seeing it as an investment in the economy. We said it during COVID, and we're continuing to act like that's not what we learned. So thank you.
All right, just put your hand up if you'd like to speak, and we've got some people who will come around with microphones and go ahead and just say who you are and go ahead.
Sure. Thank you all for this really important conversation. I'm Jenny Otnott from the One Campaign. A lot of the conversation this week is focused around the supply side, making more financing available for health and development. And while that's really important, we've been a little bit focused as well on the demand side. What are the constraints to countries in accessing health financing or asking for health financing from some of the MDBs and particularly debt-based mechanisms? At two different sessions I attended yesterday, panelists raised that the political economy of health financing to date has really been driven, at least in part and largely, by vertical funds, at least for the last 10 to 15 years, and that there needs to be a transformation there as well if we're going to look at the whole kind of systemic approach to health. So I'm curious to hear from you all on what role can some of these vertical funds play in helping spur this transformation in health financing in the next 3, 5, 10 years even. This is going to be a long-term agenda, but PEPFAR, Global Fund, Gavi, what are their roles in this and what can they be doing to help create more space?
Great. Thoughts, reactions? Whoever would like to? Go ahead. Go ahead.
Well, I was going to say, and maybe I'd really love to hear what colleagues have to say. It's a great question. I feel like we have to move away from this sort of, and building on just the brilliant things that Winnie just said and really built out the point I was trying to make earlier, I think we have to move away from even the sort of seeing these funds as vertical. Like, I don't know what vertical means because they've actually been the things that have driven and built out the health systems in a most effective way. And so I think, in fact, to me, what we need to do is build on them so that they are helping build out pandemic preparedness in ways that are, exactly as Winnie said. And what I was trying to say is so that you're actually building your pandemic preparedness by responding to the pandemics that exist now. So that's part of it, is how do we use those existing proven mechanisms and partnerships and structures to actually build the strength on things that we know how to do. So it's not just that, but I actually have more of a fear that pandemic financing could be more verticalized. And then it's going to be about things like monitoring that keeps people in rich countries or rich communities safe and doesn't actually extend the health system. And so for me, that would be, in the most fundamental way, but.
No, of course that the situation is totally different when we are talking about Africa, the Southeast Asia, and Latin America and the Caribbean. But I think that in general, in our region, fortunately, almost all countries in our region are middle-income countries. So we have a very, very few number of countries that are benefiting from these global mechanisms. And they don't understand that sometimes when a country moves from being these are not existing, just for an artificial thing, from a high-low income country to a low middle-income country, the real difference in the national budget for health is almost none. So we are trying to explore if we could have a more different ways to co-founding and to put something from the national budget and receive some support from outside. The second thing is that, of course, that this vertical initiative is very important. Of course, many routine immunization programs in some countries were built on the polio eradication initiative. But I think that you need to really assess what is the situation that you have in order to provide a more integrated and well-coordinated effort. I think that this is the challenge. We have an initiative to expedite the elimination process, and we are trying to bring together HIV, TB, for instance, because in many countries they can benefit together. And if we have them at the primary health care level, in the most affected areas, you can provide sustainability that goes beyond an external finance for 1, 2, or 3 years. So I think that, of course, this is not one size fits all. You need to really see what are the difference, because for many, many countries, if they don't receive the funds from Global Fund, from Gavi, they will not have antiretrovirals, they will not have TB treatments, they will not have vaccines. But we really need to see how we can move to really strengthen the national health systems to be able to deliver all the services and the initiatives that they need. In Latin America and the Caribbean, that we are facing a very complex epidemiological scenario if you are not dealing with non-communicable disease. And I will highlight that because we don't have donors. We have, but a very small number of donors that are really concerned about non-communicable diseases, the impact on health provided by climate change, and other important subjects that we really need to go beyond the traditional way that we are financing the health initiatives in the past. We cannot lose the support that we have now, but we really need to start a dialogue about how to use this to strengthen primary health care at the national level, to build the national capacity to deliver the services that they need.
I'd like to give two examples to make the case that Joanna has made well. First, that the vertical funds have built, transformed healthcare systems and have added a whole part to it that needs to be integrated so that we have healthcare systems that reach all those who need and serve equitably. Jamaica. I was in Jamaica. I visited part of what you would call built by the vertical funds. A wonderful center led by civil society leaders with HIV services, TB services, many other services. Works so well. And I visited another one which is part of the former health system and integrated, serves HIV, TB, and other diseases. Both are good. Jamaica, as a middle-income country, is getting less and less of these vertical funds and working to integrate what exists in civil society together with what is in the publicly funded health system. It's a challenge because this other part has empowered communities to lead for themselves and to deliver for themselves. And what you can see is that a real good challenge is there of how to keep community-led services as well as the traditional formal health services and have a system where people can choose and everyone is served. That's one example. I go to Kenya, which is more dependent on external assistance for the HIV response. I visit a center for MSM, men who have sex with men. It is such an amazing place because it protects gay men from the criminal law there. So it's a safe space. They go there when they are actually running from the law. They get HIV prevention, testing, treatment. They get TB treatment, mental health services, a whole range of complex services connected with the formal health system. Referrals are made. And I went there and I met even refugees from Uganda who have fled there and who are using the same service. This is part of the health system built by this vertical approach of HIV, but it is serving a group of people who would not get a whole range of services because of stigma and discrimination in society and a criminal law that punishes people for being who they are. So to me, this vertical approach to some diseases is building a health system for all. It isn't just this one disease. It is the health system growing to be able to serve people with dignity from wherever they are and wherever they may be. So to your point that this is about how do you build on this? How do you continue consolidating this and transforming healthcare systems? It's not about one or the other.
Let me go ahead and open it up for, maybe we'll take 2 or 3 and then as we wrap. So 1, 2, 3.
Thank you, panelists. I'm Deus Bazira from Georgetown University. I'm not going to ask a question. I'm going to give some comments and the views that you might want to consider. So I'm going to speak more around financing flows and the governance system. You've talked about the inequitable system for financing global health. I would like to look more at the efficiency aspect of that, because even when we have lots of money available in global health, it's not easily accessible. And we actually saw that during the COVID-19 pandemic. There were funds at the Global Fund that could not easily be accessed by countries because of the governance mechanisms around those funds. So I would like to propose that as some of these discussions go on, we may need to look at issues of harmonization and integration when it comes to financing. Harmonize at the global level, look at how resources flow. You can compare all these VATCO programs, you know what you're all doing, the left hand and the right hand. I agree, yes, VATCO programs do a fantastic job, but I also believe there are a lot of inefficiencies associated with them. Because, you know, resources are always going to be constrained, as the economists say. At least we have to get more for what we're already investing. So if we could harmonize at the global level, make it more efficient for decisions to be made so that resources get availed when they are needed, and then at the national level, we actually integrate. So the two are different. You harmonize so that you are all investing towards common mission. But then at the national level, we need to integrate how these investments are made. We all thought, those of us who at least were involved in the health security space, we actually thought the world was prepared to fight any pandemic. If you read all the joint external evaluation reports, a lot of countries were doing very well. The US was ranked #1 in the world to be the most prepared. So even the preparedness aspect, we need to rethink it and how we measure that preparedness. So I would like to propose that we think about interpandemic preparedness financing, because I think that's where the challenge really lies in. Pandemic preparedness is a very complex thing because of the way we think about it. It doesn't give you immediate results, and we know the people who make decisions in all these institutions are also there for the short term. They've got career goals and ambitions. They want to show quick results. If you're investing in preparedness, it's the same thing as investing in health system strengthening. You can't easily demonstrate results in 1 year, in 2 years, in 3 years. So that is not attractive for career professionals. It is the reality. We know that. So we need to be deliberate and structured in terms of what we invest in for preparedness. There is a silent pandemic that we don't normally talk about that is called antimicrobial resistance. Kills more people than a lot of these other diseases that are more prominent. So if you invested in AMR surveillance, for example, and AMR surveillance systems, you are most likely to have invested broadly in all surveillance systems of the country, because that is a problem that affects every community, every country, rich and poor. And then finally, I will end by saying we should also move away from the mindset of looking at global health and global financing as a charity model, but look at it more from a solidarity perspective. We are all in this together because what is good for me is good for you. Know that I, who might have more resources, I should take the responsibility for taking care of someone who does not. The charity model is not is not liked by both the poor and the rich. When you speak to poor countries or developing countries, they will tell you we don't like to go around begging. But we also bring a lot to the table, even for things like HIV response. A lot of developing countries bring a lot to the table, but we do not quantify that. We do not say PEPFAR or Global Fund invested $400 million in Uganda, but the Ugandan government put in $250 million, because we sort of ignore that, yet they bring the hospitals, they bring the healthcare workers, they build the roads that we all use to transport medicines. So I think as part of this global solidarity model, we need to be equitable in the way we look at things and the way we give credit and the way we measure performance. Thank you.
Thank you. All right, I'm just going to ask, I was the one who invited presentations, and I am realizing that we're running short on time. So I'm going to ask two quick interventions, and then I'll just come back very briefly for kind of last thoughts. And the big question to you all is, what's the one new thinking piece that you want to put on the table in a few sentences? But go ahead, last two. Sorry, there was one here and one there. John, go ahead.
Hi, John Hassel, AIDS Healthcare Foundation. Thank you very much, panel. I have a quick yes or no question. The World Bank defines middle income as $2.50 a day per capita. If they changed it to $10 a day per capita, would it make a difference, particularly Dr. Barbosa, in the comments you made that most of the member states of PAHO are middle income countries? Would that make a difference in Jamaica and parts of Latin America? Just a yes or no question. Thank you.
I'll give you a chance in your one.
Yes.
Go ahead. Good. And last piece, please.
Morning, everyone. Jan Iliaker from Global Health Advocates. Thank you for this wonderful discussion, distinguished speakers. Just a quick question for all of you, because we've seen that the global health landscape is under a lot of scrutiny right now with the so-called vertical funds and how they should be thought differently. And in the meantime, even though we have this multilateral development banks reform undergoing, we don't have enough focus on the global health impact of this reform that are called. So according to you, what would be the main recommendation to make sure that these multilateral development banks can work better together with other global health initiatives and to make sure that they work toward the same goal of ending global health inequities and that they deliver and operate toward the momentum for regionalization and the global health sovereignty that we need right now. Thank you.
And so with apologies for not having another half an hour for discussion, let me just go ahead and I might start down with Joanne, with you on that end, and just come this way for some kind of concluding thoughts that might speak to our last question, and might also just put out there, if we're trying to encapsulate out of this panel some new thinking, is there a particular piece that you want to put on the table that's concrete and ideally with apologies short?
I mean, a couple of things. One, I mean, that just came up a lot that I think we just have to figure out also how to support and finance is this regional capacity issue. So that just came up strongly. And, I think we need to figure out the streams of financing for that. I mean, the other, just to build off what my colleague, Jan raised, I think it's, I'll say this, as an advocate, I understand, to some degree, some of the real constraints that even high-income countries are facing. We need to stop saying that as if it's a reality and that they're not making choices about what they do politically. So we have to actually not allow that to become, it is true that Kenya has a real constraint that they can't pay, a sort of budget space because of debt. We have to stop kind of giving into an excuse of high-income countries about how they choose to use their resources when they're still using such an immensely small part of their resources in solidarity, as you said. So we got to do better on that. And I think we got to make sure that when we look at things like the MDBs and others, that we are not just ensuring that we maximize the quantity of resources to go to these things, but the quality and how do we use it to leverage equity. And I think it was sort of interesting, some of the stuff that you raised in the discussion paper you just put out, Jan, about how do we actually do that better.
Thanks, Justice.
Thanks. If you permit me quickly to to address one of the comments that came up. I mean, the issue of governance and the challenges around governance are very much. I haven't seen Professor Agustin around, but he has done a lot around some of the governance issues that affect countries specifically. There are a couple of book chapters that we did together also on Jennifer's paper around some of how these global challenges, the challenges with global governance and justice actually affect countries. The multilateral development banks, they have more money together than we are trying to get a pandemic fund to raise. It's as simple as that. So we cannot afford not to bring them around the table. What new thing have I, not learned, but I want to echo, what colleagues already say, that to be better prepared for the next pandemic is simply ensuring that what we are delivering now, we continue to deliver them. But, and often this is where the integration question comes in, and about the global financial institutions. Ensure that those areas that we are somehow moving focus away from, neglected tropical diseases, and some of those other areas are also better funded to ensure that we all work together as we have the global, we call them vertical funds, some call them vertical funds, but I think they are very necessary because they are made to address specific areas. Let's ensure that we do not focus too much on the names of those funds, HIV, TB, so we think is funding only HIV and TB, but ensure that we actually, in the process, are addressing systemic issues that also, influence the way we deliver on other platforms. Thank you.
Thank you. Jarbas.
No, thank you. I answered yes to the question because if we don't use the equity lens to address the situation in Latin America and the Caribbean, I think that it will be all the needs that you have in this region not be assessed. Because if you put together all the poor families in the middle-income countries that we have in Latin America and the Caribbean, this should be one of the countries with the biggest population in the region, but they are not a country, so we cannot. Sometimes the financial institutions, I think that they are not looking to the situation with this equity lens that they needed to do. Second, I think that thinking about the present and the future, after every public health crisis, and when we look to SARS and we look to pandemic influenza 29 is the same, we have a window of opportunity that will last, 1 year, 2 years. So we really need to take this opportunity to rethink and about all the lessons that we learned from the pandemic. How to have the countries better prepared, because no country was prepared to face the pandemic, because the model that we had was dealing with something like SARS or MERS, coronavirus that spread slowly, so we had time to control it, or like the influenza pandemic 2009, that spread very fast, but they didn't produce severe cases to overwhelm the health service. We had both working together, unfortunately, during this pandemic. And this can happen again. So I think that we need to really rethink what's the preparedness, what are the indicators that we use, how we can have a financing mechanism that will support building this national capacity. And lastly, I think that to have real universal systems, universal health systems that can reduce the out-of-pocket expenditure, that is one of the most important economic barriers, but it's not the only one. We have social, we have cultural barriers in the region, because if indigenous people cannot have in their language, they will not come together, they will not come back, to the health center. So I think that we really need how we can remove these barriers and use this financial mechanism to strengthen a universal health system based on primary health care. Thank you.
Last word.
Oh, thank you. We must return to rights, health as a human right. And we must go away, as Deus said. By the way, Deus is from my village. See how great we are in our village in Uganda. That we must go away from the models that are based on charity and address the big issues in the global economy that prevent people from enjoying their right to health and solve them from the point of view of equity and solidarity. We have focused here on financing the healthcare system so that it delivers to everybody their right to health. And we see challenges in the international financial system, an absence of a mechanism that all countries can go to get the money they need. That has to be resolved. But also, we talked about access to medicines, the cost of medicines, the rules that allow prices to be put out of reach for the majority of people. So resolving those questions remains a challenge for the international community, and solving them as issues of solidarity. We need each other. One part cannot be well and another part not well. But then coming back also to the question of the policies at the country level, the human rights that people, all the other human rights that people must enjoy to be able to claim to have good health, a right to education. So this is the time now for this idea of global public goods, global public investments, so that we agree that the safety of our planet, that means getting ourselves back from the brink of a climate disaster, education for our children, our health, that these are global public goods and that we'll pay for them together, that every country will contribute and every country will take out for its needs. This idea has been around for a long time, but it's remained at the level of an idea. But today, as we face these multiple crises in the world, it is time to come to it, back to it, and put the pieces together for global public investment where health is paid for everybody by all of us. I think this is not out of reach. We already have different kinds of funds established to solve health challenges, education challenges in the developing world. We now need to expand them and make them for all people, for all countries, and we all contribute to them. This, for me, is the big thing that could solve the many problems, but always starting from the human rights of everybody, right to your health, the right to your education, and everybody enjoying it. That is my last thought. Thanks.
Well, thank you. And please join me in thanking the panel for a really interesting conversation. It leaves to me to give a last word to Chris Collins, president of Friends of the Global Fight, who co-sponsored this event, and to thank and acknowledge a few of the people in the audience who are new to their positions. So just an acknowledgement to Christine Stegling and to Anjali Achakar, who are the new deputy executive directors at UNAIDS, and to Deus Bazira, who is the new director of the Global Health Institute here at Georgetown. Thank you guys for being here. Yes, sure. And then Chris, last words. Here, can I hand you?
Well, thank you to a wonderful panel. That was really a wonderful discussion, very educational. It is great to co-sponsor this with Georgetown and with UNAIDS. You know, today's discussion makes it clearer to me than ever that we need a global health financing movement. That's what we need, and we all need to be part of it. And the thing about global health financing that I'm realizing is it's really complex. I don't have a PhD in health financing, and sometimes it gets in my way in terms of knowing what the ask is in global health financing. But we can't let that complexity get in the way of us forming a movement. And, you know, the AIDS movement, not everybody involved in that was a scientist, but they got the education they needed and they pushed for action. We need to do that we need to find a way to build a movement in global health financing ourselves. And part of that is us defining what pandemic preparedness is. As several people have said, it isn't just a technocratic endeavor. It isn't just surveillance. It's about people. It's about community health workers. It's about ending AIDS, TB, and malaria today. It's about finding those synergies. And at the same time, finding how to harness those vertical programs, those disease-specific programs, and keep the political support for them all around the world, including in Washington. And that's going to be a challenge, but it's something our burgeoning movement can do. You know, it's going to take shining a light on what the cost is of chronically under-financing health. We need to show the impact. We need to celebrate the advances like the Global Fund drawing down new funds. And we need to articulate the path forward. But I look forward to being part of building a movement with all of you, and great discussion. Thank you.